because it's time to start now, and I'd like
Okay.
to welcome all participants to this webinar. My name is Jean-Louis Vincent, and I am the president of the World Federation. And Mervyn Singer and I will be happy to speak about the so-called new definitions of sepsis. Mervyn Singer is professor at the UCL in London. And we also have here Phil Taylor, who is the CEO of the World Federation based in London. And thank you, Phil, for having put all the things together so that we can have these discussions. I see we have a number of people participating. I just received a message from Laura from Australia, who is there. So hello, Laura. Good evening. It must be quite late for you, but we are very pleased to have you with us. So this is the very first webinar of the World Federation, and Laura said thank you. So very kind. I don't know if you see that. I suppose you do. And so this is our very first webinar, and so we are still experiencing these things. And Mervyn's collaborators are coming in, pushing their share, and they will join us. So Mervyn, my good friend, you can start, and I will interrupt you many times.
So hello everyone. The way we'll do it, I'll talk, and after each slide, Jean-Louis will add comments if he feels the need. And clearly, if you have questions, do please type them in, and then Phil will collect any questions you may have. So without further ado, hopefully you'll have seen the paper, and there are two accompanying papers which give more of the detail as to how we derive the definitions and the clinical criteria. So they're the science underpinning the definitions. And lots of people have viewed the manuscript. Interestingly, it's interesting how people don't necessarily get it right. And I've read editorials where things are said that aren't actually in the paper. So my big plea is please do read the paper for yourself, and and that's the best way of understanding what we've written. I think, and Jean-Louis was also on the task force, and I think, what is sepsis? It's a syndrome. There's no magic blood test, laboratory test, and so forth. And so we apply this broad term to an incompletely understood process, and that's the challenge. You've got young and old, urosepsis, pneumonia, peritonitis, and we put them all together and call them septic. So there is a challenge inherent to this. So therefore, we tried to develop as best we could new definitions which were based on science. So we wanted to use data to actually help us come up with clear definitions and clear criteria, which could then be applied across the board, whether you are in Australia, Belgium, UK, Timbuktu, wherever. And so we can all talk the same language. Jean-Louis, do you want to add anything?
Yes, I do. I agree with you that people sometimes misinterpret what we wrote, and that's why we are having this discussion now to make sure that we clarify some of these elements. I don't agree that we are trying to put together peritonitis and pneumonia and other forms of infection. A peritonitis will remain separate from a pneumonia and from a urinary tract infection. But sometimes, indeed, we do not know what the source may be, and the patient may be septic, and we don't know what the primary organ is. We will go back to that in a moment, but I'm not sure that these are new definitions. I was against the idea that these represents the sepsis 3 definitions, because to me, in the common language, sepsis has always been organ dysfunction associated with an infection, or infection plus organ dysfunction. And so we are just returning to our common language. There is nothing new in there. But that's part also of the misunderstanding, because some people think that we replaced SIRS by Q-SOFA, which is not true. But again, we will speak about it in just a moment. Do you agree? You disagree? You agree in part?
Yeah. Yeah, no, I agree, Pat. I think Jean-Louis is definitely old enough, and I'm just about old enough to remember before 1982, when, you know, the 92, when the bone criteria came out. And so they to be fair to them, this was the use of SIRS, severe sepsis, etc. This was to try and give some sort of framework. And as I agree with Jean-Louis that we're returning to where we were, but many people will have forgotten where we were.
And we may actually go back further. Well, first of all, when you say 1992, many people say 1992, but that's when it was published, because the consensus took place in 1991. But that's a minor thing. But some people say that sepsis was first defined in 1991. But that's not true. The word sepsis existed much before, and the ancient Greeks were already using it. But just to go to more recent history, Bone proposed the sepsis syndrome before that. So it's not true that ever started in 1991, not at all. In 1991, there was a wrong approach, which was the introduction of SIRS. And that was the terrible mistake of our colleagues in 1991.
So as with all good progress, we reinvent what's already been happening for years. We'll move on. So we had the 1991 and the 2002. There was a repeat task force then that basically felt that the 1991 criteria were not necessarily perfect by any means, but there wasn't enough knowledge to make a big change to the existing criteria. So they just expanded.
No, I don't agree. I don't agree.
Go on then, disagree.
If they had been clever enough in 1991, they would have simply said that sepsis is infection plus organ dysfunction. They could have said that. And so the SIRS was clearly a mistake. There was no reason to introduce that. And some people were happy because there were some apparently strict criteria, but they were wrong, because the SIRS criteria characterize infection and not sepsis. So that,
which I agree. But
you know,
you were on the 2000
equal to infection, which was terrible.
Yeah, but you were on the 2002 task force.
Yeah. And so, yeah, I can say that I think it was 2001 actually, and we published it in 2003. But okay. I was responsible for the group, the small group, which had to come up with a list of signs and symptoms of sepsis, and we came out with a long list of signs and symptoms, and we thought that this would be more accurate. To say that sepsis could be associated with shock, with ARDS, with organ dysfunction, basically, and we listed them all, but people thought that this was confusing and too long, and that was our mistake. We came out with a too long table and no simple criteria, and that's how people continue to use the 1991 criteria. Agree?
Exactly. I totally agree. And as I'll show later on in the slides, it's caused big issues in terms of the epidemiology. So we had this sort of paradigm of this continuum: infection, sepsis, severe sepsis, septic shock, and it's not really a continuum at all. And we've recognized that
it could be a continuum, but I suppose what you are saying is not always the same. It's not typically the same. And in particular,
Correct.
people may not start from infection and go into
Correct.
sepsis and septic shock. Very often, patients present to us with septic shock already.
Correct.
But it doesn't mean that there is no continuum, but it's not always so obvious, right?
Agreed. But it became, I think, in the last 10, 20 years, we've recognized that sepsis isn't just about a pro-inflammatory response. There was this big overlap, infection and sepsis. So you have a bit of a temperature, you have a white count that makes you septic. We'll talk about that later. Again, this construct, so SIRS, and I think Jean-Louis and I are in absolute agreement that SIRS is part of a normal host response to an infection. It doesn't necessarily mean it's pathological, and sepsis giving you organ dysfunction is much more likely to be pathological.
It's not a reaction to an infection, it's part of the infection, right? That's how we identify an infection. That's how we know we have a viral infection, because we have fever and some tachycardia. And
but it's the host responding to the infection.
Exactly. No. Host responds to an invasion, to a microorganism. But it's part, what we call an infection is precisely this invasion, this bacterial process with some host response. Otherwise, it would be colonization or an infection, perhaps in an immunocompromised host who cannot build the fever response and the tachycardia.
Yeah, but you can have a localized infection without necessarily a systemic response. You know, a boil on your bottom.
Well, yeah,
so,
okay. If it's minor,
so we'll move away from boils on bottoms. So we also didn't have very clear definitions or criteria for what organ dysfunction meant, and likewise shock meant different things to different people.
Although I'm not so sure that we need a precise criteria for organ dysfunction in our everyday life. Of course, it's different for a scientific publication where we need to quantify the things as much as possible and use scores, etc. But in our everyday life, you know, very often the doctor on the floor calls us saying, you know, the patient seems to be oliguric, and we don't say, oh, tell me exactly how much urinated, or, you know, the platelet count is a bit low. Oh, no, it's not low enough, whatever. The important thing is the qualitative change, and we may not need to have a very precise quantification. Right?
No, I totally agree with you. I think the problem when it comes to the epidemiology, research studies, etc., that different criteria are applied, and that's caused a lot of confusion.
Exactly.
So if we deal first of all with infection and sepsis, so we went to big data to look at, you know, how to come up with the recommendations we did, and they're predominantly from large US hospital electronic health records and databases. So yes, it's, you know, preferably we have worldwide databases, but for these, they were available from US hospitals. Over 5 million patient encounters in big and small hospitals, community and teaching hospitals. And from those, Chris Seymour, who did the hard work, he's at Pittsburgh, he pulled out patients who had had blood taken for blood cultures, antibiotics started for suspected infection, and 850,000 patients fulfilled that criteria. And 90% of these patients were outside the ICU, in the emergency department or the ward. The majority, and I think one of the things, I think Jean-Louis will agree with me, we were keen that sepsis shouldn't be an ICU condition. It needs to be recognised in the emergency department, the ward, pre-hospital, and acted upon promptly.
Absolutely. Early, promptly, and completely. Yeah.
Just to show, this is the Pittsburgh, Pennsylvania cohort, just to show to me an interesting point. This is 12 hospitals, big and small, 1.3 million patient encounters, 11% were cultured and treated for infection. That's 149,000. And of these, only 4% died. So the majority of patients treated for infection survived. Obviously, this doesn't include organ dysfunction and morbidity, but only a minority of patients in hospital treated for infection ended up dying. And we don't know what did they die of. Did they die of the infection or with the infection? So they may have underlying terminal disease.
Shall we ever know that? Do you think that we could know what they die of? I mean, it's very rare that a patient dies from a myocardial infarction in the hospital or a massive pulmonary embolism.
But it may be that they've been admitted with terminal cancer and the infection thing that's finished them off. So did they die of the infection, or did they die of the fact they had terminal cancer and it was the kindest thing for them to happen?
But that's very important, and it becomes something a bit philosophical. But when people say there are so many people dying of cancer in the world every year, yeah, of course. But as you say, they may die from the terminal cancer, and then they may develop sepsis at the very end of their life. So when our friends involved in the World Sepsis Day say that Muhammad Ali died of sepsis, okay, maybe, but we know that he had terminal Parkinson's disease and it was clearly the end of his life. So perhaps sepsis was a good thing there. And in terms of ethical implications, we should not necessarily jump on all sepsis patients and try to resuscitate them, because it may be a way of dying. So for some patients, sepsis may actually perhaps be welcome. If you have terminal Alzheimer's disease and you develop sepsis, maybe okay, right?
Yeah, no, 100% agree. 100% agree. The other thing we don't know, which also compounds the problem, is just because the patient was cultured and given an antibiotic, how many of them were actually truly infected? The host response, the tachycardia, the temperature, may be due to many other things rather than infection. So clearly, we actually get a bug in somewhere between 30 to 50, 60% of cases. So does that mean a failure of our microbiology lab, or the fact they didn't have an infection in the first place? Again, we don't know. Jean-Louis.
Yeah, and there are patients who may be infected, truly infected, but we cannot find the source and we cannot find the microorganism because all microbiological tests are negative. But that negativity does not exclude the presence of an infection, right? We may have,
absolutely,
we may see an infection, but without good documentation of it, but it remains an infection.
Yeah. Our current ability to diagnose infection accurately is weak. It will get better.
Yeah, relatively weak. Yeah.
So when you just plug the figures in, only 1 in 200 of the entire population going through the doors of these hospitals in Pennsylvania died of or with sepsis, because I think Jean-Louis would agree also that to die of infection, you have to have organ dysfunction.
So yes, I agree. But so you went through a good deal of data just to come up with this number, which is important. But when you start by saying that, oh, we had a huge database, 1,300,000, it's just to show that only a small minority of patients with infection will die of sepsis. That's the message, isn't it?
Yeah, but I think it's getting it into perspective, though, isn't it?
Yeah, I agree.
Let's now talk about SIRS, because Jean-Louis loves SIRS and he's really sad to see it go. He's written lots of editorials over the years saying, goodbye to SIRS, no SIRS.
I prefer a woman to SIRS, but...
Okay, fair enough. So now you can have madams.
Madams, yeah.
Mademoiselle. So SIRS often, with most infections, is an appropriate body response. You know, even a bad cold, you can have a temperature, a white count, tachycardia, whatever. It doesn't necessarily mean this infection makes the patient septic. So the language is often confused. And so we need to differentiate a straightforward infection, which isn't life-threatening, from an infection which is bad. In other words, endangers the patient's life or gives them a significant morbidity. And there are lots of studies, and I'll just show a couple in a minute, where SIRS has both sensitivity and specificity issues. Jean-Louis.
Shall we speak about the number of cases along with time, or is it the right time to discuss it?
Yeah, I've got, well, these two studies.
No, that's not what I mean. No.
Oh.
If you can go back, you know, what I mean is that people have said that the number of sepsis cases increased tremendously around the globe. And this is essentially because with these definitions, infection equals sepsis. And so people were encouraged to report sepsis cases in the US. And actually there were some reimbursement issues, some financial consequences, but also in other parts of the world, including in Australia, where they saw the number of sepsis cases increasing, but mortality from sepsis go down and down and down. But that's primarily because they called infections sepsis. And so it was really time to have our consensus group here, because we were going in the wall. I mean, everybody at the end would have sepsis at one time or another when he or she is hospitalized. I mean, it's ridiculous. So this was really going in the wrong direction. Agree?
No, I agree. I haven't got the slide in this set, but to give an example, there are some large American sort of representative databases which shows that the incidence of sepsis has gone up 300% nearly in 6-7 years, which is clearly not right. And so it depends, as you say, you know, how you define it, characterize it, you know, financial reimbursement issues, etc. So there's been this explosion of sepsis cases, and then you'll also, because of that, the number of patients dying as a proportion goes down, but it looks, relatively speaking, that things are improving. But the reality is the absolute number of patients dying of related organ failure is actually the same or even going up.
Yeah, and people liked to see these numbers because first it gave support to the research in the field of sepsis, and it supported our role. And at the same time, it shows that we make progress because our mortality rates go down. We are good. We are very good. And so people were very pleased with these numbers. Now, on the other hand, a contrario, we may actually see now, in the years to come, the number of sepsis cases going down and the mortality rates going up. People may feel a bit, you know, say, okay, well, you know, there are less and less septic patients. That's good. That's because, you know, we wash our hands when we're going to have vaccines and da 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 da. Oh, but the mortality rates go up. We are less and less good. So we must be prepared for this kind of psychologically relevant issue.
So that means we don't need to wash our hands anymore.
Right.
Just to show, again, many patients, this is Australasian data, but many patients admitted to Australasian ICUs with infection-related organ dysfunction do not have the 2 SIRS criteria or more, which were involved in making them septic, as according to the old definition. So clearly, and you can see here, about 15% in each of the 0 or 1 SIRS criteria being met died, but by the old definition they weren't septic. And on the other hand,
And
Sorry.
you know, we say that in sepsis, the patients may have fever or hypothermia, but sometimes they may just be at the middle and have a normal temperature. And likewise, the heart rate may be relatively normal. So this is not too surprising, after all, that one may have sepsis without the criteria.
I absolutely agree. And on the other hand, you may have SIRS from many other causes. And the lower panel shows a US study where about half of the patients on the ward at any one time, at least once in their hospital stay, have SIRS, and they aren't necessarily infected. And so you've got issues with sensitivity and specificity.
So this is really a very important paper, the Surpak paper published last year, because it also shows that we could not improve the system by asking to be called whenever the patient meets the SIRS criteria. We as ICU doctors or sepsis teams or outreach teams, you can call it as you like, we could not go and look after the patients who meet the SIRS criteria on the floor. It would be just unrealistic and inefficient. And of course, I mean, if a patient has a minor wound infection following surgery, why would we call a sepsis team if it just needs some local treatment plus perhaps some antibiotics, but nothing else? We don't need an ICU team to treat these patients.
Yeah, no, I agree totally. And I think we'll come back to it later on, but SIRS, and Jean-Louis made the point at the beginning of this webinar, certainly has a place when you're looking at a patient. Could they have an infection? But it doesn't mean that they are septic with organ dysfunction. We then come to the questions of what do we mean by organ dysfunction and shock. And this is an example when we looked at what literature had been published, what criteria we used to describe septic shock. The literature's full of various permutations, combinations of blood pressure and with or without fluid, certain amounts of fluid, lactate, base deficit levels, use of pressors, new onset organ dysfunction. So because of this, you had this huge variability in mortality, and we found a fourfold variation in the incidence, sorry, a tenfold variation in the incidence and a fourfold variation in mortality. Is this a true reflection or just the way you characterize septic shock? And so again, we need to talk the same language.
Yeah, I totally agree. I want to call everyone's attention on the fact that, you know, in most of these studies, the mortality rates from septic shock, you know, are somewhere in between 40 and 60%. So when people say that the mortality from septic shock is around 25%, I totally disagree. And it's higher than that. And but it's also important to see the kind of studies we are evaluating. What I mean is that for clinical trials evaluating the effects of interventions, we have a number of exclusion criteria, and we would exclude patients with DNR orders and therapeutic limitations in the broad sense. We would exclude cirrhotic patients, etc., having a worse outcome. Whereas in real life, when we look at all our cases of septic shock in our institution, we have a number of patients who have severe comorbidities and therapeutic limitations. So the mortality rates from septic shock still today are quite high.
Yeah, no, I agree. And again, when it comes to trials, clearly if you overestimate your control group mortality, then the sample size calculations are immediately flawed. And many trials, therefore, are underpowered because the control group mortalities are much lower.
Exactly.